culturally safe and culturally sensitive care. Second, respect every woman's right to access and receive non-discriminatory and free or at least affordable care. Third step, routinely provide mother, baby, family, maternity care. Incorporate value and partnership-based, grounded on evidence-based and driven by health needs and expectations from the woman, and it's got to be cost-effective. 4, acknowledge a woman's right to continuous support during labor and birth. This is something we're trying to implement worldwide, that every woman has a right to have a companion at birth. 5, offer non-pharmacological comfort and pain relief measures during labor as a first option. We're not against epidural, we're not against medication for pain, but we think we can offer women some choices before that, which will help them during labor. 6, provide evidence-based practice beneficial for the mother-baby family throughout the entire childbearing continuum. 7, very important, avoid potentially harmful procedures and practices that have insufficient evidence of benefit, outweighing risk for routine or frequent use in normal pregnancy. And we list them. So if you go to our website, and we have some information for you at the end, where we'll tell you where to go to the website to get more information. 8, implement measures that enhance wellness and prevent illness for the mother-baby family. So you can see here that we're not about or against baby-friendly hospital. No, we're including that. But we want to be mother-friendly, and more important too, also family-friendly. 9, provide appropriate obstetrical, neonatal, and emergency treatment where needed. So we want safe birth. So natural birth can be done with safety in mind. 10, have a supportive human resource policy in place for recruitment and retention of dedicated staff. 11, provide a continuum of collaborative care with relevant healthcare providers. And you will hear from some of our speakers where they have incorporated other healthcare professionals in the delivery of labor care. And 12, very important, promote breastfeeding and skin-to-skin contact, referring to the 10 steps of the baby-friendly hospital. And this initiative of FIGO is with the International Confederation of Midwives and also the International Pediatric Association. So without further ado, I'll ask Pius to introduce the first 2 speakers.
Thank you. So our first speaker is Dr. Pakan Koka, who's an obstetrician and gynecologist and proud of birth with no regret. And he's also Lamasse certified childbirth educator and trained hypnobirth. He has pioneered a model of obstetricians to work in partnership with midwives and birth psychologists to promote collaboration in positive birth. You're welcome. He's from Turkey.
Dear Chairman and dear guests, it's an honor to be here talking to you. I am Hakan Çoker, an obstetrician from Istanbul, Turkey, and I have nothing to disclose about. And beside being a standard obstetrician after 19 years, which my aim was just to, have a healthy baby with heart beating and breathing, I came across childbirth education, and which changed all my life, which I will mention soon. Just few news about Turkey. We have 1,035,000 births. It's going down in the last 5 years. But the important thing is the 55% are these in state hospitals and 43% are in private hospitals. So it's a different way of service in Turkey now. The home births are going down from 10% to 2% nowadays. And our cesarean rate, I think we're the biggest in the world now, 58.4 last year. And if you divide it to state hospitals, it's 44. University hospitals, 73, and private ones are 75. In some of them, up to 90. our neonatal mortality rates, luckily, are going down and down every year. Intervention rates, as a summary, you see, are high still. The proper statistics we can't reach really one by one, so this is changing between 20 to 90% in especially private hospitals. So, because of all these, the cultural changes already occurred since 2005. Now, people think that birth is dangerous, risky, and there's fear of birth for families, like all over the world, is going up. And especially for obstetricians, they are scared about malpractice laws and courts and lawyers. And this made the cesareans getting more and more, and also more convenient for the obstetricians. And nobody wants any single risk in birth. So under these conditions, in 2008, I thought I would better get out of the system and work in the private system so I can change everything. And after I joined this childbirth education, everything changed. Now I see that there is more need for the support of the woman. And it took me through Lamaz Hypnobirthing Active Birth, then International Mother-Baby Childbirth Initiative, and in the end, ICI, the global supporter of the respectful birth, and we work together. Childbirth education made me to think that I must do something, and then I decided not to care women without any childbirth education, so we can speak the same language. So we made a team of an obstetrician, midwife, also working as a doula, and also birth psychologist, and we three of us took care of the woman since 2010. What's changed in our practice? First of all, we respected all birth preferences. It's not a group that aim the normal birth at only. Every woman has preferences, and it should be respected. So it is very familiar, very friendly with ICS step 1. Of course, informed choice, it sounds nice, but you should also let the woman know about their rights. So that's then we decided to do shared decision making, not deciding for them, telling them what's wrong, what's the options. If they don't understand, continue the explanation and give them enough time to decide. So it is very friendly with ICS step 1 and 3. The team consists of an obstetrician, midwife, and birth psychologist. I'll tell more about it. It is very friendly with step 4. It says offer continuous support. Drug-free continuous comfort measures are the main practice taught to families, plus every member of the team knows about it. So that lowered down our drug techniques compared with the drug-free techniques. Drug-free comforts. And evidence-based practice was the routine. The knowledge is still there. Evidence says don't do routine interventions. You just follow the books, what's written in the obstetrics, pediatrician and midwifery books. And it is running with ICI step 6 and WHO 2018 guide. And we stopped routine interventions. Step 7 says avoid harmful practices. It didn't change our routine. We had less complications by not using routine interventions. And all the hospital staff, of course, after you do all these, you need a hospital who respect all this. So wherever we go, we decided to talk to the administration and educate them for 12 steps of ICI. And step 10 says also have a supportive human resource policy. So every single staff coming to the service was educated about the 12 steps. And the golden hour, skin-to-skin contact, was the most important thing, because this is the only step that a woman can control after birth. There was something new we did. We used birth psychologist-centered service, which means a therapist who is experienced in birth take care of the woman before birth and during birth. So using psychodrama in prenatal education, labor and birth made families understand birth better. And she did prenatal sessions with the families so that mother, father, and the extended relatives understand birth and work together. And maybe the best thing for us, for obstetricians, this birth psychologist took active role in birth, which means she came to every single birth to support the family, not only the family, but also the medical staff, which made our work much easier. 12 steps were 100% respected with the support of this birth psychologist, and the aim is not all vaginal births, water births, or any birth. The aim was birth with no regrets, so that the family can get out of the room with positive experiences. And of course, after the birth, we added checkups to follow up the depression rates. These are general results. The cesarean rate is under the around the World Health Organization recommendations. The routine NMR, continuous IVs and extra, we never did it. Epidural rates were nearly 5%. Labor induction rates went down to 10% because of the risk specs until 42 weeks. Pitocin during labor and augmentation was 2 to 5%. We had normal cord clamping, 95%. Episiotomy rates went down to less than 10%. Vacuum extractions, 4%, and bonding, which is the most important, went up to 95%, which means at least 1 hour. And father's participation and bonding, 100%, and mortality morbidity rates were nearly up to 0, and postpartum depression was only 2, but they had past story of depression. And we had only 1% NICU administration. These are some of the books that our work was published in.
1 minute.
Okay, and in the end, of course, you have to do something about this. You can't work on your own. So we educated people in childbirth education and doula training. Obstetricians, midwives, nurses, and psychologists and doulas sat together so that they can also become a team. And we also educated the hospital. It takes nearly 1 year. It's not an easy work. And up to 3 to 4 years nearly to adjust all these applications. These are the pictures from the rooms. And the birth numbers of the hospital went up in 5 years' time, and cesarean rates started going down from 80% to 57%. This is the whole numbers of the hospital. And total interventions went down in 5 years from 90% to nearly 10 to 20%. And the positive interventions like late cord clamping, golden hours, and mother-friendly cesareans went up nearly over 80%. We really respect families being there, and attachment of the golden hour, and all cesareans we try to keep the mother and the baby together, and we also don't forget the fathers so that they have the attachment with the baby immediately together. In the end, last sentence is, as Michel Oden says, there are 2 kinds of birth, one with love, one without love. The aim should be empowering women to give birth by supporting them in all ways through the guidance of evidence. Thank you very much.
Thank you very much, Dr. Coca. Our next panelist is Karen. Karen is a nursing officer in charge of Lola Community Alliance in Kenya, in East Africa. She has done a lot of work in relation to respectful care. She's registered and experienced in community health, nurse, midwife, led practice, which has a degree in community health. as well as a higher national diploma in comprehensive reproductive health, and 8 years experience working in maternity and child health, and very enthusiastic in assisting women's reproductive health, newborn and children in rural area. Let's welcome Karen, and after all the 4 panelists, then we'll have discussion. Karen, you're welcome.
Thank you so much. Thank you for the opportunity. My name is Karen Siele from Luala Community Alliance. So allow me to talk about Luala, what Luala do to the community and to the government facility. So Luala was basically founded in 2007 by a group of committed Kenyans who are currently working abroad. They are medical doctors. So our community-led model rests in 4 pillars. We have our community health workers, community committees, health facilities, and data. We incorporate traditional birth attendants into the community health cadres in the hospital and train them as the community health care workers to bring service closer to the communities. We strengthen communities, community-led accountability mechanism. We also improve the quality of care in the public hospital. And we partner with the government. We train community health care workers to bring health services closer to the communities. We also help public hospital to improve the quality of care and to adapt the policies and practices that strengthen the health system. Over the 15 years that we've been in existence in Kenya, we've been able to generate evidence-based practice where 99% of the women are able to be attended by skilled providers. They are no longer delivering at home. Children under 5 are 3 times more likely to receive health services, and women are 2.6 times more likely to use contraception. We focus on system change that leads to scale. We are working to transform health care access for 1.1 million people in Migori County, as well as enabling government and partner to adapt and implement our community-led model. Our theory of change. If traditional birth attendants are included in the community healthcare workers and are trained, they are professionalized, they are stipend, then health and wellness outcome will improve. If primary health services are more available and high quality, if communities have mechanisms to provide feedback and build accountability and trust, data exists to inform policies and intervention, then health system will be stronger and more efficient to support women. So our view in terms of maternal and perinatal death, Kenya is one of the countries that have high maternal mortality, but we've seen a slight increase from 362 births per 100,000 life birth to 355 per 100,000 life birth, which is much greater when it is compared to the global health, which is at 223 per 100,000 life birth. So in Migori County, it has high burden of maternal mortality, and in our country is one of the 15 counties which is contributing to 98% of maternal mortality burden in Kenya. The current infant mortality is still high in Kenya, and currently we've seen a lot of decline from 2021 to 2023, where we are at 30.629 by 1,000 life birth. So implementation of International Child Birth Initiative, so Luala partnered with the International Child Birth Initiative, becomes the first to be recognized as the high tier implementing site in Kenya and in our country. In 2022, We did the first training that we trained midwife, nurses, and the clinical officers in 2022, and a total of 20 healthcare providers were trained. In 2023, we also conducted another orientation to increase the number of midwives who are supporting birth and labor. And this was done in June 2023, and we were able to train 29 participants to support two facilities, that is Douala facility and Minyanya facility. Objective of the workshop was to introduce the International Childbirth Initiative concept, the 12 steps of respectful mother-child care, introduce the respectful maternal care concept and respectful maternal care resource package, focusing on women and infant rights. We also discussed on the global and context-specific evidence on this respect and abuse during facility-based childbirth, discussed the proven best practices and intervention to promote respectful mother, baby, family, maternity care, and discussed the participant role in terms of providing respectful maternity care services. And we also developed an action plan on how the two facilities were going to implement the ICI intervention. So the impact was seen from 2022, from 2022 April, when we started the implementation of ICI program. So there were increase in number of staff knowledge in terms of handling mothers with respectful care. We also witnessed an increase in the number of mothers accessing antenatal services, whereby 100% of women are able to attend at least first antenatal care before they deliver. There was also no maternal mortality reported since the implementation of ICI project in 2022. There was no neonatal death reported in 2022, and compared to the past years like 2021 where we had 2 mortalities. There was also increase in the number of childbirths in the hospital setting, and in Douala facility we witnessed an increase of from 807 to 846 in 2022. We also saw an increase significant in terms of reduction in maternal mortality during labor and childbirth processes. So when we were comparing data and looking how the ICI have actually supported in terms of increasing the stillbirth and reducing mortality, so we saw a lot of increase, and when you get on the data for 2023, we are looking forward to an increase in the number of women who are being attended by skilled healthcare provider in the facility, and also reduction in terms of neonatal mortalities. We also did implementation of doula. Doula we introduced this year, and we were trained a number of healthcare providers, the patient attendants who were supporting in the facilities, and also community healthcare workers. So the patient attendants role was basically to do hospital general cleaning, housekeeping services, waste collection. Their duty was being done on a daily basis. CW role before the training were in the community-based activities, doing household visitation to pregnant women, lactating mothers, community health education. They were also doing a lot of advocacy and migration at the community and facilitating referral for the children and pregnant women to the hospitals. So we met with the management, we discussed with the donor foundation, and we were able to train them so that they were allocated to work in the facilities in different shifts to support women during the childbirth process. So a team of participants were trained, and the implementation is happening in 2 facilities in Migori County, that is Douala Community Health Center and Minyanya Health Center. So we selected participants participated in giving consent, and also the training began. So a total of 24 healthcare providers were trained. The Donor International Foundation curriculum was covered, and patient attendance role were actually changed from cleaning the hospital to helping the women, 24 hours coverage in a day. And then of course there were also creation of additional space to accommodate the women who were delivering in the hospital, and a whole site orientation was done to help the healthcare providers, especially the midwife, because they spend most of the time taking care of the women. So we also did a lot of orientation to doula services, and then of course conducting community dialogue and community engagement to tell the communities that there are doulas who are available to continue providing care to the women. And then we purchased labor and birthing tools, and we also are looking forward to document success stories and monitoring the data. And of course, we started childbirth classes for women and birth companion, and then we do a meeting with the doulas and track the progress. So in 2023, we also did maternity exit interview just to gauge how we are able to provide dignity, respectful care, and to see right information, informed consent, and respect to women. And we were getting on information like provision of dignity to women. And we saw a lot of women who actually encouraged participation during labor and birthing processes. And of course, provided with respectful care were 98%. 95% of care providers were able to address the women by calling them through their name because they were able to create rapport and they had existing knowledge. Healthcare providers were able to introduce themselves to the mothers, and of course, fewer women were asked which position they would like to deliver, because in Kenya we are used to lithotomy position, and when we introduced ICI, it was very good to let the women choose the position that they want to give birth. So in terms of right to information,
Please conclude.
thank you so much, and thank you so much. So baseline interviews, it was also to get the quality of maternity service, engagement with the mothers and the healthcare providers, and their lesson learned. Booking women for childbirth will decrease the quality of care during labor and birthing processes, and also improving the communication will also give our women a chance to choose the birthing position, and of course orientate women and on the healthcare workers on the birthing position, and doulas advocated to support maternity care. Thank you so much, and sorry for taking your time.
Thank you very much. I'm pleased to introduce Dr. Jeanne Sibiud, gynecologist obstetrician from France, from the Hospital Louis Morier, assistant professor at the University of Paris. She's the president of the Obstetrics Committee of the French College of Obstetrician Gynecologists, CNGOF, and coordinator of the National Guidelines in Obstetrics. She holds a PhD in epidemiology. She is an expert in infectious disease and pregnancy, and also studying access to care and quality of life in populations affected by these infections. Welcome.
Thank you very much, Andre, and thank you to the organizers for inviting me. I'll open my slide. Okay. So this is my disclosure slide. And so the question in quality of care is how to reduce maternal and neonatal morbidity. In France, we do not have a national ongoing program on quality of care, but I will show you what we do and how we monitor quality of care indicators. They are evaluated regularly on a national level. This is the Enquête Nationale Périnatale, which I will introduce later. And there are a list of quality of care indicators that has been established by the National College of Midwives and OB/GYN specialists. There are also national guidelines that were edicted by the Haute Autorité de Santé, which is the Ministry of Health, an organ of the Ministry of Health. And then, of course, what also is of prime importance today is going beyond the question of safety and considering the preference and respect of women who give birth. So which quality of care indicators to consider? This was a study that was conducted by OTIPOG in collaboration with the College of Gynecologists and Midwives from France. And there was a Delphi procedure to determine quality of care indicators that will be accepted and judged relevant for all professionals. And this study established a set of 50 indicators to be measured. But as you can see on this slide, these indicators concerned onset of labor, delivery, neonatal morbidity, and mortality. The focus was really mainly on safety and not really with inclusion of women's preference or experience. In 2017, the National Guidelines on Normal Childbirth really insisted on this question of women preference, as the first objective of the guidelines was to define for women at low obstetrical risk management procedures that respect spontaneous rhythm and progress of birth and the preferences of women, trying to really decrease non-necessary medical procedures. The second objective was to improve and ensure the quality and safety of care for the mother and neonate. And so there was a review of literature conducted by a work group with midwives, OB/GYN specialists, pediatricians, anesthesiologists, and public health specialists and expert patients. And you can see here the key messages. The first key message was that women and couples should be educated to help them make informed choices, and the discussion should be initiated with the caregiver team to best consider their preferences and expectations and to make women active partners in their delivery. And then the other key messages was especially about trying to limit unnecessary medical interventions. What did the national guidelines say in 2017? They really tried to give some guidelines on when is intervention necessary. So the first thing, at admission, discuss birth plan, and then in France we tried to really separate the latent phase and the active phase in order to decrease intervention during the latent phase at least, where no intervention is necessary, even if labor is not progressing really quickly as we used to expect, like 1 centimeter dilation for an hour. This really changed. Vaginal exam was proposed to the women every 2 to 4 hours. Intermittent auscultation was possible. They could eat and drink. And we tried to support women as much as possible in their choice in terms of non-pharmacological interventions, as in the ICI program, immersion, relaxation, acupuncture, hypnosis, or massages to manage pain, and not always the epidural as being the first answer. And then, according to women's preference, of course, local regional anesthesia may be performed. And then we gave other guidelines concerning active phase and descent phase. How do we then evaluate the evolution of our main quality of care indicators? This is through the Enquête Nationale Périnatale, which is a survey that concerns all women and all children born after 22 weeks gestation or 500 grams in every single maternity ward during 1 week. And this survey is done every 5 to 7 years. There are questionnaires about the hospital itself, and you can see that over 99% of the maternity wards participated. And then there is a questionnaire at birth and a follow-up at 2 months for this 2021 edition. It was the first time that there was this follow-up at 2 months for the women. And 96% of all births are captured by this Enquête Nationale Périnatale during this 1 week. What could we see in the last report of this study? We can see that although the guidelines are trying to decrease medical intervention, while induction of delivery has progressed. You can see here between 1995 and 2021, and today it's 25% of births that are induced in France. There is no change in the planned cesarean section that are about 10%, but we can see an important decrease in the last 3 surveys in the use of oxytocin and artificial rupture of membranes that has really decreased following the guidelines. The mode of delivery has not changed much. In France, we have about 21% of cesarean concerning emergency and planned cesarean put together, and it has not really changed. And we have about 12% of operative delivery, which is pretty high compared to most other countries. Operative delivery is mostly vacuum extractions and less today forceps and such. One other thing that has really decreased following the guidelines of 2017 is the rate of episiotomy. So the first thing that it's the first time that we evaluate women's experience and mental health 2 months after delivery. And what we found was that after 2 months, 17% of women scored higher than 13 at the PDS, postpartum depression test, which is a high score. Another thing that we that we evaluated was that 96% of them said they were either satisfied or very satisfied by the pregnancy follow-up and delivery. However, in another question that was asked at the same time, 11% said that remembering the delivery for them was a very bad memory. And 12% said that they had been victim of inappropriate words, gestures, or attitudes during their stay in the hospital. And that is what they said 2 months after. So how can we better meet our patients' expectation and act in a more respectful manner? We try to continue to increase safety. Delivery is also a very special moment for the family, and although the guidelines already were stressing the well-being of the women, we have known 2 other things. The first thing is a birth plan, a national task force to encourage the writing and taking into account of women's birth plans with different chapters and under chapters, asking what are your resources and your strengths to live this pregnancy? Would you like to communicate some elements of your story, personal past or recent, that would help us accompany you better, etc. Trying to really get to know the patient better. So this is the first tool between patient and healthcare professional that we're hoping will really help us. And the second, and this is my next to last slide, it's something that is quite close to the ICI program, is a label for maternity wards, to try to have these 12 recommendations, transparency of maternity, try to increase information, the comfort of the newborn, the autonomy of the patients, and 12 recommendations like this, and you can see that having non-pharmacological pain is also the step number 9. And this is the College of Gynecologists and Obstetricians that has developed this label. The difficulty of this label is it's made by a private company, and so the cost must be taken on by the hospitals. And for now, it has not been adopted by the majority of hospitals. This is my last slide. We have several tools for improvement of quality of care during labor and delivery. Both aspects must be taken in consideration, the improvement and regular evaluation of quality of care for safety, and also the experience and wishes of women on their delivery. Reduction of unnecessary medical intervention, but do not forget that access to care to all who need it is also necessary. And thank you very much.
Merci beaucoup, thank you very much. Our last but not least speaker is Dr. Bengal, Professor and Head of the Department of Obstetrics and Gynecology from the DBVP Rural Medical College in India. He is the President of the Alani Obstetrics and Gynecology Society, founding member of the Organization of Women and Health Together, and a member of the governing body of the nationwide Quality of Care Network. Welcome.
Good afternoon, everyone. Respected chairpersons, fellow colleagues, and my friends. At the outset, I thank FIGO and International Childbirth Initiative for giving me this opportunity to present before you. I am presenting our experience of implementing 12 steps of International Childbirth Initiative at my facility. I am working in a rural-based medical college institution having almost 12,000 deliveries per year, and we have implemented this project for around 18 months or so. As you all know that India is one of the most populous countries in the world, and the maternal health is influenced by a lot many cultural traditions and practices. Fortunately, there has been a large incidence now of institutional deliveries taking place, and the original doctor-centric approach is still prevalent, that we really do not give a lot of importance to what women want or what women expect from the services. So this is a small brief presentation about my work at this Gowda Institute. I bring greetings from there. I have nothing to disclose, and I'm happy to say that our facility is recognized as an initiator phase 1 facility for ICC. Gowda Institute and the Maternity Hospital follows the core values of empathy, compassion, respect, care and support, and does give autonomy, importance to the autonomy, confidentiality, non-discrimination and privacy. So these are some of the pictures that are from my institution, where we provide dignified maternity care. This is the picture of a labor room ambience in which we provide privacy and confidentiality to our women. The posters and of the respectful maternity care has been displayed, and all the staff members are properly oriented towards RMC. We often get suggestions from our clients, and we give importance to what they have to say about the quality of services they have received. So I'm sharing the experience of implementation of 12 steps of ICI at tertiary care hospital. Purpose was to assess the effect of implementation of these 12 steps. It was an international project. All healthcare providers involved in maternity healthcare services were trained in provision of respectful maternity care. This was the team at my place in which all doctors, nurses, paramedical workers, healthcare workers were provided training about the 12 steps of ICC. We did little analysis using point of care quality improvement program methodology, and then we found that we cannot really implement all 12 steps together, but when we found that what is most important is step 1, step 5 and step 7. So step 1 deals with treating women with compassion, respect, dignity, 5 with pain relief measures other than pharmacological measures, and 7 being stoppage of potentially harmful procedures and practices. So all the training sessions were conducted in due course of time. Step 1, giving every woman her choice, providing her choice for type of delivery she wants to have, and also the position for the delivery she has. Traditionally, all the women used to be delivered in a supine or lithotomy position, but now, these last 2 years, almost 4,000 deliveries have been conducted using alternate birthing positions. And my postgraduate student is here. He is presenting a poster, Dr. Rohan, on these alternate birthing positions, almost 4,000, and with the maternal and perinatal data. So this is another thing which we have included, and we are asking them their choice of delivery. Step 3 was routinely providing the mother, baby, family maternity care, and the women after delivery are supported throughout their stay, and lactation counselor is at their help if at all they develop any. Labor companion has become a routine. All 100% deliveries are being attended and in the presence of labor companion. We offer all non-pharmacological comfort and pain relief measures using birthing balls, peanut balls, massage, and maybe hot water soothing effect we are using. Then even a music therapy has been kept in the labor room. We also use aromatherapy, and all this has been added in the last 2 years. Step 7, avoiding potentially harmful practices. As it has been said by previous speakers also, there are not many things which are done unnecessarily in the labor room which have harmful effects on the outcome. So we have started monitoring all these: induction of labor, augmentation, C-section, ANTSL, episiotomy. So all these are being routinely monitored, and necessary corrections are being done whenever we find that something is going wrong. Step 9, provide appropriate obstetric, neonatal and emergency care. All the labor room 24 hours, 365 days is ready to deal with all the emergencies, and all the doctors and nurses have been trained in providing emergency obstetric care. Not only that, but we have gone beyond the institution and developed a helpline with all other peripheral hospitals, and all the hospitals are directly connected to our labor room, and whenever they want any advice, we are happy to provide them that. We conduct, after this implementation, focus group discussion with the women and their birth companions and asking their feedback using provided by ICI that we have converted into local language in Marathi. All the questions have been translated and they have been used. The feedback of almost 1,120 women and their companions have been compiled and analyzed. It shows that there has been a lot of improvement in many of the aspects of maternity care. Previously, nobody used to introduce that's come down significantly. Even before this, the breastfeeding and all, the early initiation of breastfeeding and rooming in all the practices were being followed as per the and we are happy that further improvement has taken place after implementation of ICC. The key results were 86% of the women were satisfied with the quality of maternity care at the end of 18 months, 4% of the women felt physically abused, and 6% felt verbally abused. Women felt encouraged and confident during labor when the person of their choice were allowed with them. Staff were understanding and compassionate according to 84% of the women. 80% of the women felt encouraged by the staff to have safe and positive labor and birth. With the passage of time,